Next up, we're going to dig a little deeper into cardiac sarcoidosis. Our guest speaker today came from Yale University. Battled snow to be here with us today, so we appreciate him for that. Dr. Edward J. Miller.
All right. Well, thanks to Kelly and everybody for putting this on the Foundation for Sarcoidosis Research. I mean, what a great event. We do patient outreach events in our clinic at Yale, and it's one of my favorite activities to do to really invigorates the clinical and research aspect of my life. Let's see this one. There we go. Okay, so I'm a cardiologist, but I also direct the nuclear cardiology laboratory at Yale, and so the focus of my clinical and research work, a lot of it is on the use of PET scanning in cardiac sarcoidosis. I do see patients with sarcoidosis and other what we call infiltrative heart diseases on a weekly basis. So having that cross-pollination of understanding how the test influences patients is something that I think is something I can bring to the table. So I framed this presentation about cardiac sarcoidosis from a patient's perspective, and I actually titled it, "What questions should the patients ask?" But it's actually what questions do the patients ask me all the time, okay? So I have these disclosures. Actually, one of these is a really good one, is that we have some research funding from a pharmaceutical company to study sarcoidosis, in cardiac sarcoidosis and imaging, but it's always like to put up the disclosures. So here are the three most common questions I get from patients. Do I have cardiac sarcoidosis? Do I need a defibrillator? And do I need to take steroids? I bet if I ask people in this room, we've all had one or three of these different questions. And so I'm going to go through each one of these and give you my perspective on it. Now, there's a lot of data and opinion coming out about cardiac sarcoidosis. I started my involvement with this disease about a decade ago, and I've seen that even in the past 5 years, our understanding of the disease and how to treat it dramatically improved, although we're not even close to where we need to be. So there are two forthcoming documents that I'm helping to write. These are big position statements that the societies for physicians get involved in, and then we come together and we say, well, what's the evidence show us and how should we use different topics? And these are both focused on cardiac sarcoidosis, so the standardization and delivery of this information to the medical community is forthcoming. So as the last speaker just talked about, there are a lot of unanswered questions in sarcoidosis, and these apply to cardiac disease as well. What causes it? But then within cardiac disease, it becomes who and how should we look for or screen? The treatment controversy exists in cardiac disease as well. And then I'm going to focus on two aspects of how we diagnose it and how we use some imaging techniques to evaluate it. So as the previous speaker already mentioned, a lot of patients have cardiac involvement with systemic sarcoid. The data on what percentage of people have the disorder is hampered by a lot of different biases and different case series. So one of the things that we always talk about is how we develop a large registry across ethnic, racial, and geographic lines to understand in the United States in particular what and who is involved with the disease. But in general, we think that a fair minority of patients who have sarcoidosis have cardiac involvement, but then the number of patients who die of sarcoidosis, a significant proportion of those die from cardiac involvement. So even though not everybody has it, it's a significant problem. And the involvement of the heart is difficult to understand without the use of some imaging techniques. This is an MRI scan of the heart. It's black stuff, this black circle is the heart. This white stuff is the sarcoid. And this is another part of the heart where we typically biopsy from. If we're doing this non-invasively, you can see that where we biopsy from is well away from the lesion. So this is why we can't just go take a piece of tissue of the heart and find the diagnosis. So I finished my medical training in 1999-ish. And this is around where cardiac sarcoidosis really took off as a diagnosis. And this is just a graph of the number of publications in the medical literature. If you Google search this and you graph it out, you can see, look around 2000, wow, there's this big spike in the number of publications. And that has to do with two different types of testing that in the past decade have really matured. One is PET imaging, and the other is cardiac MRI imaging. And these weren't really available before 2000, and even 2005 is when they became more standardized for this disorder. And then 2010-ish is when we really started to think that we know what we're doing to some degree. And so that's why when we talk about this disorder, a lot of the data coming pre-2000s probably has a lot of flaws in terms of how it relates to what's going on today. But nonetheless, we see an increase in sarcoidosis and cardiac involvement for a lot of different reasons. So with that background, let's answer the first question. Do I have cardiac sarcoidosis? Seems like a simple question to answer. But it's not. And the reason is that the diagnostic standard, or the gold standard, biopsy, is not applicable to most patients. And so we're relying on surrogates to help us define the probability of the disease. Now, the diagnosis of cardiac sarcoidosis is critically related to understanding whether there is extracardiac sarcoidosis. So, as a cardiologist, I like to say, well, everything's extracardiac, but everybody else is saying, well, cardiac's just a small part of the disease. Nonetheless, when we talk about when you have cardiac involvement, we think probably 80 to 90% of people have evidence of sarcoid somewhere else in their body. There are probably a small minority of patients who only have it in the heart, but the majority of people have it somewhere else, as the previous speaker just talked about, systemic involvement. So if you go to if you go to a cardiologist, this is a fairly rare disease, as many of you know, and so they'll say, well, they'll look up and say, well, how should I, what does the literature tell me to do to diagnose cardiac sarcoidosis? And they'll come across a number of criteria. This is one that's been commonly reported. It's a criteria out of Japan. The Japanese Ministry of Health and Welfare developed a set of criteria to help people decide whether people have cardiac sarcoidosis. But there are a host of problems with this criteria, which I won't go into the fine details of, but they don't apply to a lot of our patients. They're very insensitive, and they don't help us to define, as well as some other methodologies, what your risk is of having a bad event. So I don't use this Japanese Ministry of Health and Welfare criteria for most of my patient care. Recently, in 2014, a group of heart rhythm doctors, electrophysiologists, sat down and said, well, what do we think, how do we think that we should diagnose cardiac sarcoidosis? And they took a host of definitions based on whether you have a number of imaging findings or clinical findings like heart functional problems, the need for a pacemaker, and some imaging findings on PET or MRI to develop their criteria. Now their criteria is really wide open, meaning you could have just extra cardiac sarcoidosis and had heart function. That would give you a probable diagnosis of cardiac sarcoidosis in their opinion. So that creates even like a very wide basket of the diagnosis. This is probably a better criteria, although not as commonly used. This is from the World Association of Sarcoidosis and Granulomatous Lung Disease that came out again only 3 years ago. It requires the biopsy of sarcoidosis, and it defines people into whether they're highly probable, meaning they're really, really likely, 90% of the time will have it, probable or possible, whether they have a number of different clinical and imaging criteria. And this is the general approach that I think most of us use, is that we try to put people into, well, do we really think you have it, or do we kind of think you have it, or do we not think you have it in the absence of a biopsy? Now, here's our approach at Yale and other colleagues in Boston that helped us develop this. And this is how we approach people when we screen for, and I'll focus just on screening, and the treatment we'll talk about later. So we have somebody who has suspected cardiac sarcoidosis because they have extracardiac disease and they have some cardiac sign or symptom that would lead us to suspect they have cardiac involvement. Our approach is to take all those people and do a cardiac MRI. This is based on local institutional capabilities and also the better testing characteristics of this particular test. If the MRI is positive, then we proceed to another type of test called an Fdg-Pet Scan. Now these are two fundamentally different tests and look at different things. The MRI looks at scars. The Fdg-Pet looks at inflammation. So they're not the same test. They have different performance characteristics and different reasons why people would choose one versus the other. But in a simple sense, we're looking at scar versus inflammation. And then everything flows from those two pieces of information. And these are those two studies are the bedrocks now of understanding the likelihood of patients having the disease. So that's how I approach patients. Do they have cardiac sarcoidosis? We look at what their signs and symptoms are and then proceed into those imaging studies. So the second question that comes up is, do I need a defibrillator? As this gentleman pointed out quite eloquently, this can be a life-saving, but also very problematic therapy. So there are two types of defibrillators, meaning we can put them in because we think you might have an arrhythmia in the future, and we're going to base that decision whether on a risk-benefit calculation. For example, what your age is, what your heart function is, some imaging factors, and maybe even the need for a pacemaker because of other problems with the heart electrical system. So a lot of patients are falling into this, well, everybody should, this thinking, well, everybody with cardiac sarcoidosis should get a defibrillator. And I don't think that's exactly the case. There has to be some finer brush strokes to understand this. But certainly people who have had a prior life-threatening arrhythmia, they fall into what's called a secondary prevention category. Or if you've had these arrhythmias, or you've had sudden death that has been resuscitated, then certainly in the presence of cardiac sarcoidosis, secondary prevention ICDs are absolutely warranted. Now those electrophysiologists, those heart rhythm doctors who put out the 2014 statement said it would be reasonable for most people with cardiac sarcoidosis to get a defibrillator, and I agree with that with some caveats. So we tend to focus on the use of some imaging studies to, again, sway us one way or the other on whether or not somebody would need a defibrillator. This is a great data from colleagues that we collaborated with that look at the presence of scars, or what's called late gadolinium enhancement on the MRI, to look at the risk of death or arrhymnias in patients with cardiac sarcoidosis. And they took all the data that's been published and they put it all together, stir the pot up and see what came out. And they showed that in studies that have looked at a total of a couple hundred patients, under 1,000 patients, that if you don't have SCAR, that your risk of event rates, the white is, if you do have SCAR is the white. If you do have SCAR, you have a higher event rate than if you don't. And in fact, that if you don't have any SCAR on MRI, in most cases your event rate is almost zero. So we have some people who have cardiac involvement but don't have scars. Those are the patients that probably, in some cases, might not benefit from a defibrillator. So we use that MRI as a risk assessment tool. There's similar data from PET studies. This is looking at the FDG, their inflammatory signal. And I should also mention, during the PET scan, most of the time we also get a second image that looks at blood flow or perfusion. Perfusion can be a surrogate for scars, and so it's a different way of looking at scars. It's not as good as the MRI. What this data shows is that if you have normal perfusion and no inflammation, that your survival is really, really good. If you have abnormal perfusion and inflammation, your survival is worse. And so this can be some way of assessing risk for the need for a defibrillator. So now let's turn to treatment. Do I need steroids? Dr. Baumann is going to talk about this in more detail. But I don't think we know. There are big questions in the treatment of cardiac sarcoidosis. Who needs it? Is it everybody? Is it just people who have heart dysfunction? Is it people who have heart dysfunction with electrical abnormalities or heart dysfunction with arrhythmias? Should we be basing our treatment only people who we can define inflammation on, or should we look at people who have, or should we be giving it to people who we can't find inflammation on? How should we be treating them with steroids or steroid-sparing agents? How long? Should we use imaging to guide that? And how should the treatment be assessed? What type of imaging? So, since I'm if you go to a carpenter, you get a hammer, right? This is a study from art, and sorry, this is spinning so fast. So this is a PET scan of the chest. And all this black stuff up here is spinning around are lesions from sarcoid. And I can show you them in color here. This is cutting the heart, cutting the body a different way. Everything that's orange there are sarcoid lesions in the lungs. Okay, and so we can image that, and this is before steroids. And then I can give the patient steroids, and people can give the patient steroids, and the inflammation goes away. Okay, so it's pretty dramatic, and this is an area of controversy about whether we should use imaging for lung disease, sarcoidosis, but certainly we can measure it. So my opinion is some patients with cardiac sarcoidosis likely benefit from immunosuppression, and it's finding out which of those patients we should treat is something somewhat is not really known. There is some data where people have tried to tease this out, but there's never been any really good studies on this. So we use PET imaging to help decide who would need inflammation, because it can image inflammation in scar formation. It can look at heart function. It can look at disease activity in the lungs. There's some issues, though, of doing it well and interpreting it right. So I would caution, don't do this at home. But here's a typical scan. So this is a heart here. This is in the chest, and these focal dots of orange are coded to show you that these are areas of granulomatous inflammation that we can see in the heart, and we can display them in a different way. We can show them to our colleagues. Oops, there we go. And so this is again a rotating image. This is that circle, this inflammation in the heart. We can see also some disease activity in the chest. So people, and we've looked at this, we published data on this as well, that if you give people who have some degree of heart dysfunction some steroids, they probably do better. Their heart function improves. And here's that same patient that I just showed you. Now all that inflammation's gone away. So that's why, we were talking about steroids and weight gain. This is why, this is why we do it, to decrease that inflammation and look at all that stuff is gone. This is just non-specific stuff. So steroids can be very beneficial. And we published data on this that shows that if you can use PET very nicely to demonstrate a reduction in inflammation. So this is my opinion that PET imaging for cardiac disease represents the current best method to measure immunosuppressive treatment and response in cardiac sarcoidosis. And so our approach is this, that if you have disease, you have inflammation, meaning you have positive Fdg-Pet, and we think you have cardiac sarcoidosis, and you don't have any contraindication to immunosuppression, we use moderate doses of prednisone, and there's no right answer on how much to use. This is what we use, whether for better or for worse, for this long, for better or for worse, with treatment to make sure that people don't get bone leak problems or other infections. And then what we do, I think this is the important part. How much you treat for how long, that's an area of debate. But I don't think that it should be debatable, and the guidelines are going to say this, that you need to follow your treatment based on some parameter. And we think that using repeat imaging is very useful so that we can measure the reduction in inflammation. And if it doesn't go away, then we can add other agents. And maybe you add other agents at the start because you know that in some of the patients this won't adequately suppress them. But this is what we do. Now, the question that we don't know is, say you do get a reduction. How long is that going to last? Right? When should we retest? Should we repeat the testing again with unanswered questions? So this is my group. We have a great group of multidisciplinary physicians, nuclear people and pulmonary people. Work very closely with a number of groups on the East Coast to generate this data. Do I have a couple more minutes?
We have time for questions during the Q&A session.
Okay.
You do have about 4 more minutes.
Okay. So I have a couple cases. I don't know if people want to see some cases. Yes? Okay. All right. So these are anonymized. So this is sort of a typical one that I see. 53-year-old woman who had a pacemaker put in at an early age. Nobody really thought, I'm not sure why did a 50-year-old woman need a pacemaker? I don't know. In the East Coast, it can be Lyme disease. Needs a pacemaker, but it wasn't. And then she gets her pacemaker looked at, and all of a sudden, wow, she's got an arrhythmia. So at the time, she has all these normal studies. So we said, well, maybe she has sarcoid. And so we do this whole body image for Dr. Bauman, and what we're seeing here is not that there's inflammation at this time in the heart, but right here, this is in the lungs. And we're identifying that she has sarcoid from the imaging scan. She gets this biopsy and she has sarcoid. So we were able to link the reason that she had needed the pacemaker 4 years ago to the presence of extracardiac sarcoid. Now she has cardiac sarcoid by that definition. So that's a really neat way of using imaging to help understand the disease. Now this is another good case. 61-year-old man, long-standing pulmonary sarcoidosis. He gets some palpitations. So the palpitations, some fluttering in the chest would make us want to evaluate further. And he's also feeling short of breath when he exercises. So we do this PET scan, and so there's I can see a lot of bad stuff here, a lot of grayish stuff. But what we're seeing is there's nothing in the heart, but wow, he's got a lot of Goombas in his lungs. And we're able to define that his shortness of breath probably wasn't from cardiac involvement. It wasn't his heart failing. It was that and there are many other ways of doing this. Obviously, the pulmonologists can look other ways, but this really helps us to differentiate cardiac from pulmonary involvement. I think the last case, so this is a guy, 68, at age 50. He had pulmonary and lymph node sarcoidosis that was found incidentally, like many cases. Not treated, and was just being followed and seeing a pulmonologist once a year. Well, all of a sudden he gets acutely short of breath, can't do his usual squash game in New Haven. Squash is actually a thing. And he almost passes out. So he comes to the emergency room, and he has very significant EKG abnormalities. And so we do the PET scan, and right here, and sitting in his heart is a new lesion consistent with cardiac sarcoidosis. So we find that and are able to then make the diagnosis and treat him appropriately. So I look forward to your questions. I think this is a great conference. I'm really happy to be here. Lots going to happen in the next 5 years or so in this disease, particularly in the cardiac realm. There's a lot of engagement for the cardiac community and cardiac imaging community, and I think that the future is very bright.
Can you go back to your contact slide, please?
Oh, sure. Yeah.
Thank
Yeah, so this is my clinic, the phone number, and that's the email.
Thank you.